I have nothing to disclose, and I fully understand that this talking about kidney cancer may not be so exciting as talking about prostate cancer. Anyhow, please do not forget that the burden of the small renal masses, the incidental diagnosis, is increasing, and we will be obliged to choose between nothing, between partial nephrectomy or radical nephrectomy, or between having something in between. Talking about cryoablation, I can only tell you that if you look at the bars, this is a description of this supply of how the publications have been moving in the last years. If you look at the two eras in blue and in orange, you can see here that the publications in cryoablation of renal masses has been increasing in the last time. We don't have data recently. I have a little bit the feeling that publications are just zeroing, so we are a little bit in an impasse and we have to decide what to do in the next years. Probably the most attractive or the big event who has been happening in the last 8 years is moving from the laparoscopic approach to the percutaneous approach. Very few small renal masses are treated with ablation at the radiofrequency or cryoablation by a laparoscopy, though there are still some indications. If you go, I only took the American side, clinical trials Governor, and you can see that there are 19 clinical trials registered on cryoablation. 8 of them are complete. 2 have already results posted, a little bit of information, but they are not yet published. 5 were withdrawn or terminated, suspended before ending, and 3 are open, recruiting, or not yet recruiting. But we don't expect results of these trials until 22 or 28. If you look at the registries, 2 in United States that you can have access, Trace and Armor, and Eureka in Europe on cryoablation of small renal masses. The problem with all these registries is that they did not predefine the outcomes that they are going to evaluate. In most of them, the data is retrospective, and then, of course, you cannot avoid the bias. Furthermore, in the ones who have been publishing 2 or 3 publications, you have the impression that you have already been seeing what they are publishing, and this is no more and no less than the repetition of what we were publishing 10 years ago still. Problems. Houston, we do have here a serious problem. We have been unsuccessful in setting up a randomized control trial for different reasons who are out of the scope of this presentation, but both trials, European trials, were terminated because the lack of recruitment. That was really a ridiculous recruitment. Then, in absence of this high evidence, we have to move either to systematic reviews, and you may argue garbage in, garbage out, I fully agree, or to what has been happening in the last 4 years to the PRMH, the propensity score series, which are not devoid of bias, but they approach the randomized control trial. If you look at the systematic reviews, length of stay, the winner, of course, is the percutaneous cryoablation, who allows, like in this nice picture, even to treat tumors in a very difficult location. Oops. If you look at the local tumor recurrence, here, of course, favors the laparoscopic cryoablation. If a difference of 4 or 5% is clinically significant, I let it to your evaluation, but it's probably a matter of philosophy. Our friends, the radiologists, they don't have any problem in repeat the procedure 6 weeks after, or in the other side, we urologists probably we aim to treat everything in a single operation. This is, I did it in the other side, of course. In fact, what can be learned from all the systematic reviews is that residual disease is slower in laparoscopic cryoablation. Recurrence-free survival is similar at the end after retreatment. Overall survival is similar for percutaneous or laparoscopic approach, and there are no differences in the evolution of the renal function. Subtype may be irrelevant. I fully agree. You see here an overall survival curve and a recurrence-free survival curve who are not significant. But please, great matters, and there are at least 3 studies in the literature that show you that it's not only the size as proxy of the stage, but it's also the high grade. Very few in this series. Remember that we are talking about renal masses, but the high grade is dangerous in recurrence. If you look to the propensity score match studies, no difference. Most of them are based on population studies, and then again with a certain bias. And in most of them, there are no differences between radiofrequency or cryoablation, just we put everything under the label of thermal ablation. No differences with partial nephrectomy, at least for radiofrequency ablation, very small tumors. Increased all-cause mortality for thermal ablation in general, cryoablation included. Similar cancer-specific survival at 5 years for thermal ablation partial nephrectomies, and in fact, no differences in outcomes between cryoablation, radiofrequency, and one of the already not new, but a kit in the block, you call it, the microwave ablation. Ablation is associated with a worse overall survival in this propensity matched score, and similar functional impact and 1 year cumulative rates of renal insufficiency for partial nephrectomy and even for any one of the ablation, thermal ablation techniques. Probably the second thing who has been impacting is that we are pushing the boundaries of the cryoablation at least, and we are beyond treating clinical T1A masses. 2 series, one of them very small but matched from Cleveland, comparing partial nephrectomy, robotic-assisted partial nephrectomy with laparoscopic or percutaneous cryoablation, 31 patients. The partial nephrectomy, a higher rate of complications. This is not only statistically, but also clinically significant. If you look with a 20% of differences, no differences in postoperative renal function, but of course, cryoablation, a higher rate of local recurrence. The series of Detroit, which is also recently published, which 20%, almost 80 tumors larger than clinical T1A. From them, 10 tumors were T2. You may treat these patients. There are very few differences between clinical T1A and clinical T1B, but take into account that in T2, you may have a higher rate of complications and a higher rate of recurrence, local recurrence or persistence. Health-related quality of life, very important, increasing importance in the next years. This is a paper from our group, recently published, which you can see here. If you divide what is a kidney intervention with nephron-sparing surgery, cryoablation, or partial nephrectomy, there are very few differences between the 3 modalities of treatment, but the kidney approach seems to matter, and the patients who are treated percutaneously do much better than the patients who are treated by open or laparoscopic. Anyhow, at 3 months, almost all the patients recuperate the basal scores, and at 1 year, there are no differences among approaches or among modalities of treatment. Costs are a concern. Again, small series from France showing you that laparoscopic partial nephrectomy seems to be the winner. I think that there are very few indications right now for open partial nephrectomy, and that the hospital very nicely depict in this full design. You can see here that the hospitals in general may lose money when they do ablation at the radiofrequency, and much more with cryoablation, may lose money. And the major problem is still the cost of the probes. A matter of concern, still not solved, is the higher doses of radiation that the patient receives during the procedure. And those doses are higher because the procedure is a little bit longer in cryoablation than in radiofrequency. Those doses are higher in cryoablation. There is a need to consider measures to reduce the risk of radiation, like a low doses control, like spacing the time of control of the ice ball. But this is also important, that it's not only the radiation that the patient dose, the dose that the patient is going to receive during the procedure, that is also the dose that is going to receive during the follow-up. And for this, all of us have been trying to reduce or to rationalize the follow-up. Most of the recurrence are going to present in the first 2 years. Take into account that you may divide the patients between low risk of recurrence, and those are the small renal masses, clinical T1A, with 1 or 2 of nuclear grade, and ones who are clinical T1B or with a high grade. Those patients are at high risk of recurrence and require of a more strict approach in the follow-up. But still, this is an example coming from the United States, but still we need to standardize our follow-up in general in thermal ablations. In conclusion, I would say there is an increase in percutaneous approach, which is good, and in detriment of the laparoscopic approach, at least in cryoablation. The highest list of evidence, and that's not good, is derived from systematic reviews and propensity score matched studies. In the clinical T1A, there are no difference of outcomes between any of the thermal ablation, either cold or heat, in kidney and small renal masses. It may be an option, cryoablation, to treat clinical T1B. That may not be the case in radiofrequency. We will see with Dr. Carrero is telling to us. But you have to take the risk of incomplete ablation of higher recurrence rates. Health-related quality of life. I'm already done with this. Yes?
Yes.
Yeah?
Yes.
And then the most important is, I think, that we have to move to smart studies, multi-center smart studies.
Thank you.